brief overview of what we did in the past 2 days? Let me screen share. All right. So I hope my screen is visible to you all. All right. So on day one, we covered the basics of PICO, how to derive PICO from your research question, and how to make your comprehensive search strategy based on your PICO, right? We ended up concluding the more concise, clean your PICO is, everything else would be easier for you to follow. Then we had a bit of practice. We talked about Prospero. Using PICO and using keywords from our title, we made search strategy by using the synonyms of those keywords, the commonly used ones, and the mesh terms from PubMed. We joined them using Boolean operators, and we were able to get comprehensive results. And we saved those results in the form of NBIB file. And later, we uploaded those results to Ryan to perform screening. We learned how to perform screening based on the title, abstract, either full text screening. We talked how at the end of screening, you're left with a very limited number of trials that you're sure fit perfectly in your PICO and you can include in your review. At the end of screening, you're supposed to have this Prisma flow diagram filled. Then we performed ROB assessment for all the included studies, right? So we were supposed to answer some questions from the 5 domains, and the tool was supposed to tell us whether the study was high risk, low risk, or had some concerns. Based on that, we perform the ROB assessment of each study individually, and in the end, we end up with this forest plot that we're supposed to put in our manuscript. After ROB, we talked about data extraction. Here, we started talking about numbers, how you're supposed to look at all the full text trials of all the articles that you're supposed to include in your review, right? You look at the baseline characteristics, you make a table for baseline characteristic either on MS Excel or Google Sheets, right? The second and the important table that you're supposed to make is for your outcomes. You have to be very diligent when extracting your outcomes. Make sure your outcome is reported by at least 3 studies for it to be analyzed by Revman, right? We talked about how to clean our sheet, right? Because when we clean our sheet, it becomes easier to perform analysis. We just have to copy paste the numbers. We'll talk a bit more about this today as well. So today, we'll talk about data analysis, right? It's a relatively easier part, a bit tricky in the beginning since you're not used to of the interface, you're not used to of the functions. But once you get into practice with this software, it's very easy to use, and it's literally one of the easiest parts of the meta-analysis. So for data analysis, before starting it, there are certain theoretical terms that you need to be familiar with. The reason of me teaching these theory terms before starting analysis is for you to get familiar with with the options that would be selecting on Revman, right? You can't just blindly select those. You have to know why we're selecting what option, right? It's easy. I'll try to keep it as concise as I can because I plan on spending most of the time on the software rather than on theory. So why do we perform data analysis? Basically, the numbers that we've gotten from our data extraction, now we have to get some result out of it, right? That's why we extracted the sheet. So for data analysis, you perform analysis of your outcomes, right? Not for the baseline characteristics, that's for the theory part, right? You perform analysis of the outcomes that you extracted from all the trials, right? So your outcome, it could be dichotomous, it could be continuous. It's important to understand what kind of outcome you're dealing with because Revman, when you tell it that I'm going to perform analysis on this one outcome, it would ask you whether this outcome is dichotomous or it's continuous. So dichotomous means binary. The answer is yes or no. If your outcome was deaths, maybe you are there were two like drugs, right? You were comparing death rates in your population. So death has just two answers. Either it happens or it doesn't happen. It's yes or no, right? So death is the dichotomous outcome. If you were calculating the incidence of MI while using a certain intervention, if your trial was discussing about MI, right? If MI is your outcome, so MI happens or it doesn't happen, right? It's yes or no. So for the topic that we were talking about was about pitavastatin plus ezetimibe dual therapy versus pitavastatin monotherapy. So your outcomes were change in LDL levels, right? So if you say, did the LDL levels change? Yes or no? It becomes a dichotomous outcome. It's binary because there are only two options, and from those two options you can answer. But continuous outcomes are scale based. For example, I gave an example of this one study yesterday, hemodynamic effects of ketamine versus etomidate for critically ill patients. So your intervention was ketamine, your comparator group was etomidate, your population was critically ill adults, right? And your outcomes were hemodynamic outcomes. So in hemodynamic outcomes, you can calculate change in blood pressure, you can calculate heart rate, maybe the incidence of arrhythmia. So blood pressure, do you think it's a dichotomous outcome or a continuous outcome? If someone asks you, what is your patient's blood pressure? Would you say yes or no? No, you would give them numbers, and those numbers could be infinite, right? Someone could have a blood pressure of 180 by 20, 190 by 80, maybe like 150 by 70, something like, you would have different answers. So those outcomes that have a different number of answers to them are called continuous outcomes. Whereas dichotomous outcomes are always binary. You either have it or you don't have it. For the incidence of arrhythmia, that would be a dichotomous outcome because you either have arrhythmia or you don't, right? So this is the very basic introduction of these outcomes. So why is it important to know whether your outcome is dichotomous or continuous? Why is Revman asking you this? It's asking you because the way Revman analyzes dichotomous outcome or continuous outcome is different. It uses different method to calculate dichotomous, and it uses different method or different measure to calculate your continuous outcomes. That is why it's important to correctly tell Revman what kind of outcome you're dealing with. Now, if your outcome is dichotomous, right, then your effect measure means the measure that Revman is using to give you the results. It's going to be either risk ratio, odds ratio, or hazards ratio. We'll talk about each of them, but this you need to memorize, right? Whenever it's a dichotomous outcome, the effect measure that you would be using or Revman would be using would be risk ratio, odds ratio, or hazards ratio, right? Risk, odds, or hazards of a certain event, right? But if if you have a continuous outcome like blood pressure, like pain, like fatigue, right? Scale-based answers. For those, your effect measure would be either mean difference or SMD, standard mean difference, right? You just have to select these options in Revman. It's not important to know the details of each of them, but I would give you a very brief introduction of them. Now, for effect measures, the way Revman analyzes dichotomous outcomes, it could be risk ratio, right? What is risk ratio? Basically, the risk of any event happening, the risk that certain event could happen, right? Like it could be, see the example that I've written. You don't have to learn these formulas or even interpretation because Revman does that for you. You get the forest plot, and from that you can interpret. But this is just the theory part if someone wants to read it, but I'll explain the example. In example, you can see group A treatment, 10 events in 100 people. That means 100 people who were taking the drug only 10 of them experienced headache, right? Headache is what? It's a dichotomous outcome. You either have it or you don't, right? Group B is control. In group B, that were not taking the drug, it's placebo, 20 events in 100 people. Out of those 100 patients that were taking the drug, only 20 had headache, right? So the risk of a certain event, of a certain adverse effect in a population or in a group is called as risk ratio, right? Um, so you interpret in a way, if risk ratio is 1, it means there is no difference between the risk of a certain event happening in either the treatment group or the control group. Means it's the same. If risk ratio is less than 1, it means that risk is lower in group A. Group A is your intervention. If risk ratio is greater than 1, it means there is higher risk of that adverse effect happening in group A, right? Less than 1, lower risk. Greater than 1, higher risk. You don't have to learn this, but it's just, it's better to know what does it mean if risk ratio is less than 1, what does it mean if it's more than 1. We'll repeat all of this when we're interpreting the forest plots, but for now, just try to get the concept what it is all about. The next effect measure for dichotomous outcome is odds ratio, right? The odds of a certain event, right? For example, group A had 10 events and group and 90 non-events. That means out of 100 patients, only 10 developed headache and 90 did not, right? That's what we talked about in risk ratio as well. But how is odds ratio different? Basically, it gives you the odds. It gives you a ratio between the two groups. If 10 person had headache and 90 did not, then the odds ratio of the event in the two event and non-event group would be 1:9, right? It gives you an answer in the form of a ratio. So it's more or less the same thing, but a little different in terms of interpretation. Hazard ratio. Hazard ratio is for survival. For example, um, you're performing a meta-analysis, you're conducting a meta-analysis in a certain drug, right? And you see that you want to see what are the survival rates in patients who are taking these drugs compared to patients who are not. So if group A, that is the intervention group, has 50% survival at 5 years, that like they've been taking the drug, uh, it means that if someone gets diagnosed today, after 5 years, what are the rates of their survival? 50%. Half of them would die. Group B, if someone got diagnosed today, after 5 years, 25% would survive. Like out of 100, 75 would die and only 25 would survive. So this is in the form of a percentage, and it's the survival analysis. It's your survival rate, right? You can, if it's less than 1, Group A has lower risk. If it's greater than 1, again, like risk ratio, group A has higher risk. This was just to get you guys familiar with the effect measures. The second effect measures for continuous outcomes. Continuous outcomes, the outcomes that are scale-based, that have different answers, right? The only difference between the two is that you use mean difference when the scale used for your outcomes is the same. If the scale was different, for example, pain, you could use different studies could use different scales to report pain. Many different scales for depression, for fatigue, right? So if the scales are different within your outcomes, right, then you use SMD, standard mean difference. But if the unit is same, like blood pressure, right, it's going to be in millimeter of mercury, right? If the unit is same, mean difference, if it's different, then SMD, right? So even if you don't, end up remembering any of this, I want you to remember just this. If your outcome is dichotomous, the effect measure you'll use is either risk ratio, odds ratio, or hazards ratio. And if your outcome is continuous, you'd be using mean difference or standard mean difference. That's it. Right. Now, since now we know we're familiar with a few terms when it comes to analysis, now we can move forward with our analysis. So first off, I would open the extraction sheet that we used yesterday. So this was the sheet, right? I'll clean another outcome for you. So basically, you analyze each outcome separately. You have to analyze the outcome, nothing else, not the intervention, not the control group, nothing else, just your outcome, right? So my outcome for now is change in LDL. So these are the 4 studies. This was the extraction sheet that I made, right? This is outcome number 1, that was change in LDL. And what's the unit? It was in milligram per deciliters, right? And this is it. So what I'm going to do is I'll take this data, this. The yellow one is for, we're not considering the yellow one because it had unconverted values and later we had to convert them because they had given values in some other unit. So these two are the same studies. I'm taking this one because it's of the same unit, right? These 3 I'm going to analyze. How I'm going to do that? First off, I'll write change in LDL. You can just manually type as well in Revman, but I don't usually do that because there's, greater chance of error when you're typing. So I clean my sheet here in the extraction table, right? And then I just copy paste it. It seems much easier to me. So then I'm going to make my, see, change in LDL, then I'm going to make 2 columns under it. I'm going to merge these 2. Here I'm going to write dual therapy, just dual therapy. You can write the names of drugs as well. If you want to do it with me, you can absolutely do it because then you can perform analysis with me. Right? Just open Excel and do what I'm doing. Just copy numbers from my screen. Dual therapy versus mono therapy. So I made 2 groups. Under the one heading, that was my outcome. Right? Then I'm going to do what? I'm going to, in dual therapy and in monotherapy, I'm going to put the values now. Now the thing is that here you can see numbers are given in the format 85.49. This is the actual value plus minus another number 26.7. That's standard deviation, right? This value is mean and after plus minus it's standard deviation. I'm not saying it from myself. It's given in the table from which I extracted the data. You can see it from there. But for my Revman basically asks these 2 numbers separately. So I can just type there as well. But what I can do is, which is much easier, I can just separate them myself here and then just later copy paste there, right? So this column would be for my mean, and the other column under dual therapy would be for standard deviation. Again, for monotherapy, I would again write mean because both have different numbers and again standard deviation. Right? Now I've made the columns. I'll just put the numbers. So see, this is the outcome. These 2 are under the 2 groups. This is the intervention group and this is the control group. Here, I'm ignoring the other weeks. I just want to check at week 12 first. I can check at week 4 as well because that also has 3 studies. But for now, what I'm doing, I would have to make another table for week 4 and another for week 12. That's the thing. You analyze literally everything separately, right? For now, I'm analyzing what is the effect of dual therapy versus monotherapy at 12 weeks, right? And later I can do at 4 weeks as well. I'm going to just copy paste these values now. What is the mean here? 85.49. And what's its standard deviation? 26.7. Here, 66.1. And its standard deviation is 22.2. Its mean, the third one, is 70.0. And the standard deviation is 14.2. Right? So there are lots of numbers. You have to be very vigilant which numbers you're analyzing, because you can't just put them randomly in Revman. You just have to, spoon feed Revman for it to give you the result. Right. For monotherapy, again, I'm going to put my values from here. For monotherapy as well, I'm taking week 12. So it would be 111.74. Standard deviation is after plus minus 27.2. Mean for my second study is 85.7. And the standard deviation is 23.0. For the third study, my mean is 88.7. And my standard deviation being 16.9. Right. So what I'm going to do is I'm going to make it look a bit prettier. I'm going to outline them. Right? So now it's a prettier table, right? And maybe I can merge these as well, so my outcome is in the center. See, now it looks much more like pleasant to look at. Now, one thing that we missed is I have to put the name of the study here because Revman would ask me that, right? So with the first three studies, it's Cho, Hagiwara, and Sujita. I'll just write the name so that I know which values from which study. So, Hagiwara, Sujita. Sujita, right. I'm going to increase. Right, looks better. I'm going to outline this as well. This is all optional, but I just like to do it. Right, looks much better. Now, change in LDL, I'll specifically write here at 12 weeks. So I know what week it is. I have to report everything. Right, going to center it. That's it. Looks beautiful. All right. Let me know how is it going for you guys. Is everything clear up till now? Let me open the chat. Okay. Are you guys following along? Were you guys making the table on Excel? It's good if you do, because then you would also be able to copy paste everything on Revman, and you can make your forest plot with me as well. How to clean the sheet? Okay, sure. Basically, what I did is I just went to the raw data that I pulled. Now I can see there are lots and lots of empty spaces, right? This I can copy paste the cleaned one directly into Revman. This I can't, right? Also, Revman asks mean and standard deviation values separately. So I can't just copy paste it, right? One way of skipping this cleaning part is to just copy paste the values, but you can't, it's more error prone, right? And I like to avoid that. What I do is within the raw sheet, I clean the data in a way. I look at my first outcome. This is my first outcome, that is change in LDL. What I do is I see how many values at least three studies report. I can see week 8 is of no use to me because I can't analyze it. It's just reported by two studies. Week 4 is reported by three studies and week 12 is reported by three studies. So these 2 weeks, under the heading of this dual therapy and monotherapy, under this one outcome, I can analyze, right? So what I'm going to do is I'm going to make a new table, a separate table for week 4 and a separate for week 12 like this. I'll just write change in LDL at 12 week or 8 week. I'll make two headings under it for dual therapy, for monotherapy, and then I'll separate the values of mean from standard deviation for me to easily copy paste into Revman, right? And I'll just take the values from above and like either paste them or type them, right? So use a lot of common sense here. I hope I was clear. Once you've done that, now everything is super easy. You just have to copy paste stuff into Revman. If you guys have downloaded Revman in your devices, that's very nice. You can follow along with me, but if you haven't, you can always watch the recordings and practice later on. Open Revman. It would open like this. So you go to right at the top, you have this option called File. You click on File and you click on New because you want to create a new review, right? Next. Now it's asking you what kind of review it is, right? Ours is an intervention review, right? So I click Next. What is my intervention? I'll just write statins for hypercholesterolemia. Hypercholesterolemia, right? That's it. Next. Protocol or full review? I'll write full review here and finish. Just like Ryan asked you some information before creating the review, Revman also asked you, and see, your review has been created. You have nothing to do with all of these headings. This is just headings of your manuscript, right? The thing that concerns us is you go to studies and references, here, left click it actually, and then go to reference to studies and left click it. An option would come add study. Now the first thing, right now, what Revman knows about my review is just the topic of the review. I know what studies I'm including. I know I have their full text. I know their Rob assessment and everything. Revman doesn't. So what I have to do is I have to add the studies that I intend on including in my review to Revman so that Revman can know what studies it's dealing with, right? And later we would add data one by one for each of those studies. So I'm going to click at add study. Now it's an included study. Next. Study ID, I would give it 1, 0, 1, just 1 maybe. Next. You don't have to do anything. Next. What was the year? Let's just say 2022. But you can get it from the extraction sheet. In study ID, I'm writing the name of the author so that it's easier for me to show. That's study number 1. Right? You don't have to do nothing. What do you want to do after the wizard is closed? What do I want to do? Do I only have one study? I had a total of 4 studies, right? Right? So I'm going to do click the option, add another study in the same section. Why? Because I have more studies to add, right? First, I'll add all the studies, just their IDs and their names. And later, once I've added all the IDs, then I'll start putting in the data for those. Continue. Now it's asking me study ID for study number 2. What was the name of the author? Let me see. Hagiwara. Study number 2 is Hagiwara. Next. Next. What was the year? Let's say 2025, right? Next, next. What do I want to do? I want to add another study in the same section. That is my study number 3. Continue. It's asking me study ID of study number 3. That is Jeong, right? Jeong. Next, next. What's the year? 2017 maybe. Next, next. I want to add my final study. That is my study number 4. Continue. What is it? It's, I think, Sujita. Sujita. Okay, I'll write 2011. Next, next. Now what I want to do? I want to do nothing because I've added all 4 of my studies. I'll say finish. Right? Now you can see here it has added all 4 of my studies. What I did was I went to the heading studies and references and I clicked it and left click reference to studies and I added 4 of my studies. See, under the heading of included studies, I can find all 4 of my studies, but their data is still empty. I have to put their data. For data, what I would do is I would go to data and analysis, the heading right under studies and references. You can see data and analysis, left click it and add comparison. Add comparison. I have added all my studies. Now Revman is asking me, what is the name of my comparison? It is dual therapy versus monotherapy, right? Next, what do I want to do? Now this is the comparison of 2 drugs. Under this comparison, I would have a number of different outcomes. For my statin study, how many outcomes did I have? I had 4 outcomes: change in LDL, HDL, cholesterol, and triglycerides. Those 4 outcomes, I need to add them, maybe one by one. First, I want to analyze what change in LDL. So what I want to do is, under this comparison, I want to add an outcome under the new comparison, right? Makes sense? Continue. Now, see, this was what we were talking about. Why it was so important to have that discussion in the beginning? Because now I want to see what kind of outcome it is. So change in LDL, what do you think what kind of outcome it is? It's a continuous outcome because it had numbers. Continuous outcome. Next. Name of this outcome they're asking. What is the name of this outcome? Change in LDL at how many weeks? 12 weeks. Group 1 is named dual therapy. You can write the names of the drugs as well, of course, I'm just trying to save time. Monotherapy is the group label 2. Next. Now, it's asking me about the statistical methods. So for the analysis model, you always choose random effects. What is the difference between fixed effect and random effect? Basically, when your studies are homogeneous, same sample size, same age of the patient, same comorbs, almost similar ratio of the gender, then you can use fixed effect because your studies are homogeneous. But for medicine related studies, it's very hard to have such homogeneous studies. You are going to have a lot of differences in terms of your sample size, age of the patients, their comorbs, right? Any of their baseline characteristic, it would be varying widely across the studies. So in order to compensate those differences, we tell Revman that we're using random effects, right? Because our studies are what? They're heterogeneous. Always choose random effect and from here choose inverse. It's already chosen inverse variance. Now, what would you choose? Mean difference or standard mean difference? Tell me in the chat. Should I choose mean difference or should I choose standard mean difference? Minha, I'll answer you in a minute. First, tell me, should I choose for my outcome, change in LDL at 12 weeks, since it's a continuous outcome, so my effect measures are either mean difference or standard mean difference. Which one should I choose? I can repeat, mean difference is for when your outcomes are same, when your unit is same, and standard mean difference when your unit was different across the studies. Yes, of course, mean difference, because LDL across all the studies was given in which unit? Milligram per deciliter. When your unit is same, you use mean difference. So you see, you have to choose these things for yourself. Revman doesn't know. So you have to know what does these things mean. Okay. So mean difference next. Keep it as it is, 95% confidence interval. I'll talk a bit about confidence interval later. Now, since the result that you get from Revman, it's in the form of a graph, right? And you have to interpret that graph to understand what is your result. So you have to tell Revman how do you want to label the graph, left side of the graph and right side. I want you can do anything here. I want left side of my graph to label dual therapy, and I want right side of my graph to label monotherapy. Right? Makes sense. Sort by study ID. Okay, that's fine. Next. Now what I want to do. I have told Revman that I'm comparing these two drugs. Then Revman asked me, what is my first outcome that I'm analyzing? My first outcome is change in LDL. I told Revman, I gave him the studies. Now what? I have to add data for that outcome that I haven't added yet, right? The one that I cleaned the sheet. Now I'll click add study data for the new outcome. Continue. Now, your question comes. Who was it? Yes, Minha, your question comes now. You asked me that only 3 studies were reporting change in LDL at 12 weeks. So why I have given Revman 4 studies? Because you have to give Revman initially all the studies that you intend on including in your review. Later, Revman will ask you, after you add every outcome, it will ask you which of the studies amongst the studies that you gave me report this outcome. Now I can include those 3 studies that were reporting change in LDL, right? So initially you have to give all of the studies because there might be some outcomes that are reported by all 4 of the studies, right? And then later, Revman would ask me which studies report this one particular outcome, and then I can choose which ones to. Am I clear? All right. Now, here. Do you remember which studies were reporting change in LDL? It was definitely Show. It was Hagiwara, and it was, which one was it? Show, Hagiwara, and Sujita, of course. Sujita. Right? Now what I will do? Finish. See, it gave me the table. I'll tell you everything about it. First off, Revman asked me, what is my comparison? What am I comparing? I told Revman I'm comparing dual therapy with monotherapy. Under that comparison, my outcome number 1, all of the outcomes would be under this one comparison. And if I want to make another comparison, then I can add another comparison by doing the same thing that I did earlier. So under comparison, my outcome number 1 was change in LDL at 12 weeks, right? Now, for this outcome, then Revman asked me, what were my groups, the dual therapy and monotherapy. Then it asked me which studies were reporting this particular outcome. These 3 studies, right? Now it has given me a very nice table. Now you understand why I separated the values of mean and standard deviation. It was for this very purpose. I intentionally cleaned my sheet or made my table in such a way that the formatting was similar to that of Revman, and I can just directly copy paste, right? Now I can copy paste. I'm going to go to my sheet and see, copy. Make sure first row is for dual and second is for mono. And also the order of studies, because it might change. Show Hagiwara Sujita. Show, yeah, it's the same. If it's not, then of course you would have to arrange it in such a way. Control. See, I had to do very little work and it gave me, my table is filled. Where is 27.2? Wait a second. Okay, I have to add another table. I forgot. See, it's asking mean, it's asking standard deviation, and there's another column for total that's asking me the sample size. So what I'm going to do, I'm just going to add one more column to it, and data is already given, right? So what I'm going to do is, insert. Mm, second. Let me see where that option went. I really can't find the option where we can just add column. But what we can do is, we can just copy paste separately. Copy this and copy it into the dual therapy columns, Control V. And for these total, I'm going to take data from the above table. You can do that as well. It's like directly copy pasting. So these were the first three studies, right? The N you have to add. N is the sample size, right? So I'm just going to copy paste it directly. You can do that as well, of course. See, now it's been added. Now for Excel, copy the other two columns for monotherapy, Control C, and go back to Revman and paste it. For total, again, I'm going to get the sample size. Here is the sample size for monotherapy, as you can see. Control C, and when your extraction sheet has everything, literally there's nothing that you need to worry about. You just have to copy paste stuff. Now, all my columns have been filled, and since I've copy pasted them, there's less chance of human error here. Now what I'm going to do is, you see the options at the top. This is for add study data. This is for change. You have to click this option, this graph option that you have with these bars. It says forest plot. When you click it, it gives you this window. This is the result of your outcome, right? Now there's a certain way to interpret it that I will teach you, but first you have to tell me, are you guys with me? Oh yeah, Minha was saying something. I'm sorry I missed. Yeah, it might have worked, but it's been a while I worked in Excel. I usually do this in Google. Okay, all right, that's good. So now I got the forest plot. Now, how do I interpret it? You see, these are the studies. This is my control group, the monotherapy. This is the weightage of each study. You see, the second study, Hagiwara, is the greatest weightage, 52. So it's going to have the greatest impact on my overall result, right? This is the mean difference, since the effect measure that we used was mean difference for this continuous outcome, right? This is the range. And at the bottom, you can see the confidence interval is 95%. Heterogeneity. What does heterogeneity mean? Heterogeneity is this entire row is heterogeneity. It's usually denoted as I square, right? I square means heterogeneity. It means how different are your studies from each other. The studies that are included in this one forest plot, how different they are from each other. The heterogeneity is 48%. It's fine. Ideally, low heterogeneity is less than 40%. But even if you end up having greater heterogeneity, you can sometimes even get like 60%, 70%. You report it as it is, right? It's not your fault that the studies differed so much amongst each other. And in the end, you can see the p-value, right? P-value is this. Can you tell me what value of P indicates that my results are significant? Very basic stats question. There's a certain value of P, a certain threshold, below which, yes, exactly. If my P-value is 0.05, that means my results are significant, right? Let's have a minute's break for Azan. All right, so we can resume now. So I was talking about the significance of p-value, right? So the single most important thing that you can interpret from your forest plot is the value of p. If it's greater than 0.05, you know your results are not significant. That does not mean you don't report it. You have to report everything, even if your results are not significant, right? That's also a result, right? So here, in our case, our value is definitely less than 0.05. That means our results are significant. What does it mean by your results being significant? It depends on your PICO, right? Our PICO said we were investigating the effect of two drugs, two interventions on lowering lipid levels in patients with hypercholesterolemia. It means that those drugs did lower lipid levels, right? In our case, LDL levels, because that's what we are assessing right now. So LDL levels at 12 weeks were significantly reduced by these interventions. That's what the P less than 0.05 says, right? I'll go back. I square means heterogeneity. It tells how different your studies were from each other. Less than 40% is low heterogeneity. Now, all of this numerical data, right, it's given in this graphical format as well. How can you interpret it? The middle line is line of no effect, right? This is my graph. You remember it asked me what it wants me to, what I wanted to label left side and right side. I said label left side as dual therapy and right side as monotherapy. That's what it did. Meaning, now you can see these small boxes at the top. Each of the small green square, this square is my study. So this square is study number 1, study 2, and study 3. You see the line that's going through the square, that's my confidence interval. That's the line of confidence interval. If the line is very big, of course, the confidence interval is large. If it's small, it means the confidence interval is small. That's what it indicates graphically. Now you can see the sizes of these vary as well. The sizes of these squares tell you about the weightage of that study. I told you second study, Hagiwara had the greatest weightage, 52.5% in the results. So it has a greater size, right? So the sizes tell the weightage and the length of the line going through the square tells you about the confidence interval. Now, what does this diamond mean? Diamond means the overall effect of all of this. All of these three studies combined, what is their effect? That is the diamond, right? Now, why are all of these small boxes towards dual therapy? It means that all of these studies favor dual therapy when it comes to lower LDL levels. Like dual therapy was more effective at lowering LDL levels at 12 weeks than monotherapy. If monotherapy was more effective, these boxes would have been on the other side, right? That's what it means. I hope you're able to interpret now what this forest plot is. We'll perform analysis for one more outcome, and I'll ask one of you randomly to interpret the forest plot for me, right? So let's go back to our extraction. Are we good till now? Is there something that I need to repeat? Let me know if I can move forward with the next outcome so we can wind up timely. Okay, okay, sure, sure. The diamond. Okay. So this is what my forest plot looks like. You can see the study names here. One column is for dual therapy, the other is for monotherapy. Then you have a column for weight of each study. Then you have the effect measure, which in our case was mean difference. At the bottom, you can see heterogeneity, which tells you about how different your studies are from each other. And p-value, it tells you about the significance of your results. Now, all of these numerical data is also given in the form of a graph that is called your forest plot, right? So you see this, the square boxes, green ones, each of them is your study. The larger the box, it means the greater weightage your study has, which in our case is study number 2. The diamond is the overall combined effect of all these three studies, right? If the diamond is towards this side, on the left side, it means it's supporting dual therapy. If it's on the left side, it's right side, it's supporting monotherapy. But If the diamond touches the middle line, it means there is no significant difference between the two. If the diamond is touching the middle line, our p-value would also be greater than 0.05 because results are not significant. Now you get what I'm saying. Whenever you come across a forest plot, first look at the p-value, if it's significant or not. If the p-value is less than 0.05, then you look at the number of studies, right? Then you look at the forest plot, right? If the diamond of the forest plot is towards a certain side, look at the labeling, which side is indicates. It's supporting that side. But if it touches the middle line, it means there's no significant difference between the two groups. That's it. That's your forest plot. So how would I, if I had to write a sentence or a short paragraph from this forest plot, how would I do it? I would just say that dual therapy, according to the forest plot, dual therapy was more effective at lowering LDL levels at 12 weeks compared to monotherapy. And the results were significant. That's it. Is it clear now? All right, we'll do it once again. If something is not clear, it would certainly get clear. Right. So I'm going back to the extraction sheet for outcome number 2. Let me see, what can I do? I can take the values at week 4. Can I? Right now, I assessed LDL, but at week 12. But I can assess LDL at week 4 as well, right? Or maybe if you want to do adverse effect, because LDL, all of these, LDL, HDL, total cholesterol, triglyceride, all of these are what? These are continuous outcomes. Do you want to do a dichotomous outcome as well? Adverse effect would be a dichotomous outcome. Either you have an adverse effect or you don't, right? So let me see an adverse effect. I think we should go with, I don't know, wait. Elevated creatine kinase. But this sheet is not very nice. It has a lot of missing data. Let me get another sheet for you guys. Let me get another one. This is the sheet for another study, right? We can take data from here. And I have cleaned this already as well. So I can show you that as well. But if you want me to clean it here, we can do that as well. See, study number. There are lots of different ways to make your extraction. There's no standardized way. Someone else made it, so it's a little different from the earlier one. See, these are the study names with their years. These are the population of the each study. This is the sample size. So we have two interventions. We're comparing landiolol with control. So this is the sample size for landiolol and this is for control, right? So the first outcome being supraventricular tachyarrhythmia. None of them have reported it. So we definitely cannot analyze it. 3 studies have reported tachycardia, right? So maybe we can take tachycardia. Can we? Yes, we can. So here I'll show you how to directly copy paste data, right? If you think cleaning the sheet is too much of a hassle, then you can definitely just move forward with copy pasting your data. So 3 studies have reported tachycardia, or maybe let's just take AFib incidence. You know why? Because a lot of studies have reported it like this. This is the raw for landiolol and this is for control. We have lots of studies reporting this outcome. So we'll just take a few and analyze it. And also AFib incidence. Is it dichotomous or is it continuous? The incidence of AFib in a certain population, when you're analyzing it, do you think it's continuous or it's dichotomous? Yes, dichotomous. Because either AFib happens or it does not. You cannot tell someone, oh, I had 0.5 AFib. No, right? There are no numbers to it. It's just incidence, how many had and how many did not. So what I'm going to do is, I'm going back to Revman, and now closing it, I'll go to, I need to make a new comparison because this is entirely new drug. Ideally a new review, but for now I can just add a new compare. I'll go to study and references, click it, left click references, add, or maybe, sure, add study, because I would have to add new studies now. Let me just take 3 studies because that's the minimum that we need to move forward. We're gonna take the first 3, right? So this study has mentioned it. What is the study 8? This is called Yoshida. So first I'm going to mention Yoshida. I'm adding new studies because I need to add Yoshida. Next. Next. It's asking me the year. What was the year? 2017. I'll just add 2017. Next. Next. What do I want to do? I want to add 3 studies, right? So what I'll say is add another study in the same section. Continue. Now it's asking me about study number 2. I'm going to go back to my sheet and see what was the next study reporting this particular outcome. I was talking about AFib incidence. I added this. Now this, 10. What is 10? Sakaguchi 2012. Sakaguchi. Next, next. 2012. Next, next. What do I want to do? I want to add my 3rd study, right? Continue. What's my 3rd study? Let me see. My 3rd study being this one, 11. 11 is Horikoshi 2017. Horikoshi 2017. Next. Now nothing. Now finish. Okay. I've added these 3 studies. Now what I want to do, data and analysis. Now I want to put data for these studies, right? I want to create a new comparison, right? Because the drugs are different. Landiolol, name of the comparison is versus control. Is that right? Next, what do I want to do? I want to add an outcome under the new comparison, right? Comparison to मैंने उसको दे दिया. What's the outcome that I'm assessing? What was the outcome? I'm assessing AFib. It's a dichotomous outcome. Next. What's the name of the outcome? AFib. Okay, maybe I'll just write here as well. Landiolol. Next. Now, always pick random effects. Now, when you put dichotomous outcome, it automatically selects this Mantel Haenszel. You have to choose inverse variance. Or it depends as well, but for now, inverse variance is fine. What am I doing? I am calculating the risk ratio. What is the risk of AFib happening in this population, right? So it would be risk ratio. Next, confidence interval stays 95%. Next. Now, I want to label my graph. Left side, I would say for landiolol, and is for, right side is for control. Next, what do I want to do? I want to add study data for this. I have given the comparison. Under that comparison, I added the first outcome, that was AFib, a dichotomous outcome. Now I have to add data for that same outcome. Add study data for the new outcome. Continue. Now, see, these are all the studies that I've given to the system as of yet under this one review. But what were the 3 studies reporting that outcome? I have the option of including them. What are those? Those were Horikoshi, Sakaguchi, and Yoshida. Right. Right. Finish. I have the data now. You see the table is different. For dichotomous outcome, it would only ask me event and total, event and total. Whereas for continuous outcome, it was asking me mean and standard deviation, right? So that's how the table varies. Now what I'm going to do is, since I haven't cleaned the sheet, I'll just copy paste stuff. I'll go back to my sheet, and the 3 studies were which? I know their numbers. Those were 8, 10, and 11. 8 is 0, 1. I'll write 0, 1, 0 here, and 1 here. Control. I'll first write the events and then the sample size will be written later. For Sakaguchi, I can see, which was study number 10, it was 6 in the landiolol group and 16 in the control. Ignore the percentage because they're not asking me about the percentage, just the number, just the event. Landiolol has 6 and control has 16. So landiolol has 6 and control has 16. For Yoshida, let me go back. I can see in the row 11, 1 and 7 respectively. 1 for landiolol and 7 for control. Now I'm going to put the sample size. Right, 8. The sample size for landiolol group is 39 and for control is 40. Put them respectively. The total event for the total patients, 39 for landiolol and 40 for control. Similarly, I can calculate for Sakaguchi as well, which was study number 10. Both of them have 30. Right? For Yoshida, I can see it is 19 and 20. 19, sorry, 19 here. 19 and 20. Right? So I fill in my table. I can already see my forest plot, but what I'm going to do is I've given it all the data that I have, the events and the total for each of the group. And now I'm going to calculate the forest plot. Now, can someone interpret it for me? What does this forest plot mean? The way I told you. Or maybe just tell me the significance of results. What does the graph mean? Can someone volunteer to open their mic? Or maybe just tell in the chat. Come on, guys. I need to know if you guys understood it. Yes, that's correct. Landiolol is preferable because the diamond is on the landiolol side. Okay. Now tell me the significance of results with respect to p-value. What's the p-value? It's 0.03. Yes, p-value also suggests that my result is significant. When I look at the diamond, which is the combined effect of all the three small boxes, it also tells me that it's favoring towards the landiolol group. It means landiolol is effective in reducing the incidence of AFib in this population compared to control, right? Can you tell me which study had the greatest weightage in this result? Let me open the forest plot again. Which study had the greatest weightage? You can tell it from the number as well and from the size of the square as well. Yes, exactly. Sakaguchi has more weightage. Square box is bigger than the others. Right? You can either tell from the column or you can tell from the size as well. What is the heterogeneity here? What is the heterogeneity? It's 0%. That's nice. Because my studies are very similar to each other. That's why. Right? You can see they have added risk ratio here because the effect measure we have used for this dichotomous outcome is risk ratio. So we have covered how to analyze and interpret the forest plot for your continuous outcome and for your dichotomous outcome. See, it's this easy. It all comes down to how concise and how clear you are about your FIFO, right? And how well you have extracted the data, how well and how clean is your extraction sheet. Then you just have to put in numbers and it gives you the results. So if by the end of this 3 days marathon, if you're able to interpret a study, a forest plot, you know what a meta-analysis is and you can interpret the results of a meta-analysis. This is something so many people, even who are like who working on multiple projects, they struggle with, because these are the basic concepts that you need to clear before starting your work on meta-analysis, right? If you're unable to download, you can download both of the tools. They're free to use. You might need to enable them from your either your file manager or your settings. It depends on your laptop that you're using. But check the settings. It might not be enabled, right? You can easily run it either on, I sent the link for both Windows or for Mac. These are free softwares. You can use them. Revman is not free. The one that I sent you is a crack version. Sure. Yeah, now you're done. Now you've done literally everything. Now everything is very scattered. Everything is everywhere, right? Job is somewhere, your flow diagram is somewhere, right? Your extraction sheet is somewhere. How to compile it together and submit it to the journal. You just have to literally summarize or compile everything. You've done everything at this point. There's nothing new you have to do besides from writing an introduction. I'll open a sample manuscript for you guys and I'll tell you how the headings go. Now this is important to listen carefully because now I'm kind of summarizing everything together. We would be done shortly. And if you have any questions in mind, you can ask me at the end. Now I'm opening the sample. Here, right? Look carefully. So this was an actual meta that we were discussing right from the beginning. It's with the journal and it's been 2 months That's why you have to be very patient with journals, because the journal that we submitted to, the mean time to first decision is literally 140 days. That's more than 4 months. It takes more than 4 months for a journal, for this particular journal, to tell you whether it's accepted or not, whether you have a revision or not. And then when you have a revision, you make the changes, you submit to them again, and then it would take a lot of time after that as well. So that is why it takes many, many months, and in some cases, maybe years, to publish full text papers. Right, so here's the title, a concise title that tells your PICO, right? Efficacy and safety is the outcome. Pitavastatin plus ezetimibe is the intervention. Your control is the pitavastatin monotherapy, and your population is hypercholesterolemia, right? And I'm only including randomized control trials. These are all the authors. You do it in the end. You have to write their affiliations. This formatting depends from journal to journal. So you have to format it according to the journal's requirements. Correspondent author is the one that is submitted to the journal. First, you have to write the abstract. You do it in the end, right? Abstract has the headings that any abstract would have: objective, methods, results, conclusion, right? What's the best way to write a manuscript? It is to keep a sample manuscript right in front of you and then keep making changes according to your case, right? These are the samples that you can use, and then just change the numbers in the wordings, because the formatting literally remains the same. You have to write a well-written introduction, right? Why you're conducting this review, right? Because in a lot of cases, on topics, a meta-analysis has already been conducted, right? So you have to tell them why you have conducted this analysis, what is the rationale behind it, right? And why should the journal be accepting it? What's its relevance? What's its importance? What is something new that it's adding to the literature, right? Like any other introduction of any other manuscript. Now comes the method section, right? In the method section, first you tell data sources and search strategy, right? I'll read it. It's literally a process that you're describing. This systemic review and meta-analysis was registered in Prospero. I told you have to write the registration number. This was the registration number of Prospero. The study was conducted in accordance with the PRISMA guidelines, right? An extensive literature search was designed using Boolean operators and the PICO framework to identify relevant studies. Now, you can add this table, or if you don't want to, don't, but we added it. Basically, it defines our PICO, right? You tell them your PICO, and then you tell them the entire screening process, right? The following databases were searched: PubMed, Embase, Cochrane, right? Mesh terms and keywords and synonyms were used. You have to tell them which terms you used, right? And you have to tell them what filters you applied, randomized control trial filter, right? And the search strategy that you made, you have to give it in the form of a table as a supplementary table. You don't add it in the manuscript, it's given as a supplementary table in a lot of cases, right? You told them about the study selection process. Now the selection. On what basis did you select studies after screening? You have to tell them your PICO, right? What population, what intervention, what study type, what year, right? Animal studies were excluded. This remains the same, right? You just change the wording according to your meta-analysis. Then you tell them about your outcomes. What outcomes were you assessing? You just tell them. Then data extraction. How did you do data extraction? You have to write the initials of the name, initials of the people who conducted it, right? Data were extracted by 3 reviewers with a predefined extraction form. For continuous outcomes, the mean, standard deviation were calculated, and for dichotomous outcomes, risk ratio, odds ratio, and hazard ratio was calculated. You just have to tell about everything that you extracted, right? And then comes the heading of quality assessment, right? Everything that you did, each step that you did, you have to write it in a paragraph format. That's it, right? You have to tell them you used ROP2 tool, right? And you assess each study on the basis of these 5 domains. And if there was any disagreement, it was consulted with the third reviewer, and these are my initials, right? Then statistical analysis. How did you perform the analysis, right? We used Revman to perform analysis, right? 95% confidence interval, random effect was used, right? Dichotomous outcome using risk ratio. I square is the heterogeneity, right? And we're telling them how much heterogeneity means what. Greater than 75% was substantial, right? Now, this is about the missing data. This particular, I told you about study number 1, it had a different outcome. It had different units, so we had to convert the units. We were telling about that here. If such is the case with your review, you have to tell them, otherwise there's no need. Then the sensitivity analysis that was performed. Sensitivity analysis is for certain outcomes that you want to take your results with. For example, what exactly is sensitivity analysis? I'll tell you briefly. Basically, my heterogeneity, I had 4 studies for a certain outcome. I included 4 studies, right? My heterogeneity was 78%. It's substantial. It's too much, right? It's greater than 75%. Now I have to look for the source of heterogeneity. What is causing that much heterogeneity, right? What I would do is I would exclude one study and see what's my heterogeneity now. If it decreased to like 50 or 60%, it means the third study that I excluded, it was contributing a lot to my heterogeneity. So I keep on excluding, adding one study to check what is the source of heterogeneity. And then I have to report it in the limitation section or maybe in the method section that this particular study was adding a lot of heterogeneity. So analysis was performed with it and without it. That's sensitivity analysis. You're just being very transparent. And that's the correct way to report it, according to the PRISMA guidelines. Where were we? Here. Okay. Now see, we have also added characteristics of randomized controlled trials, the name of the trial, what was their population, what was their sample size, mean. These are the baseline characteristics. This is the baseline characteristic table that you have to add in the manuscript. Then these are the results for each forest plot, right? Result for total cholesterol, for triglyceride, for HDL, for adverse effects as well, any of them. Then sensitivity analysis, then discussion. In discussion, you basically discuss what new is your review adding to the literature, right? How is it different from existing literature? How it challenges them? Are there any limitations, right? And then you conclude your studies in the conclusion. You also, a good meta-analysis has its limitations. A good study has its limitations, right? You don't have to overclaim anything, right? Just report things as they are, even if there are positive findings or not, even with high heterogeneity, right? Even non-significant results, but with their limitations. And here is the conclusion. Then references, right? That's it. That's how the manuscript goes. You basically document the entire process. Introduction takes some effort, and discussion should be written by an experienced member, because that's literally the summary of everything we've done. They don't know that we've spent so much time on extraction. They don't know we've spent so much energy on screening, right? We're just narrating to them how we did it, and they'll get to know in our discussion section or in our method section. That's how it goes. It was relatively easy, relatively simple. You just take a sample in front of you, right? And then write it. Can you please send this document? It's with a journal. If it had been published, then I would have sent it. I can send one of my published manuscripts, right? Because it's not published yet, it's still with the journal. So there might be some changes that I need to make to this document. I'll send one document that's already published, right? Do we have any questions? We're done, by the way. There's nothing that we need to learn now. I hope I was able to make things simpler, make things clear. I tried my best. Okay, what will the mentorship process? So I would be mentoring only one group. most probably. Let's see, because I have my step 2 exam really soon. So, and mentorship is a marathon. You have to, be very patient with it. You have to give a lot of time to it. So, a good mentor would be very selective with their projects. So the team would decide about the mentorship and they would let you know in the group. Or you can ask them in the group as well, of course. All right. I'm really glad it was clear, Hafsa. You can always go back to the recordings, practice. And one final takeaway message is that even after taking all of this, even after, listening to the recordings, you might not be able to independently perform a meta-analysis, and that's perfectly fine because there are so many technicalities when it comes to units, when it comes to topic selection, when it comes to viability of a meta-analysis, right? There is so much that you need to have a mentor or an experienced member. Now, if you guys are on LinkedIn, you can see that lots of opportunities come that we need two people to perform Rob analysis. We need someone on a lot of research groups as well. We need someone to help with data extraction. We need someone to perform screening, right? Start reaching out to those because now you know how screening is done. You at least have an idea, and rest you will learn with practice. And once you're a part of one group, even if you just literally perform only Rob assessment in that whole project, right? You will build a rapport, right? And with time you can keep increasing your skill set. Maybe in one project you can just do Rob analysis, in another you can help with screening, in another you can do extraction. And with time you would have enough experience and enough, you know you would get the hang of things that you can come up with your own topics as well. That's the way to go about it. Keep looking for topics if you can find it, but it's hard. Topics are very saturated. It's hard for even us to uh, find a viable topic for meta-analysis, especially intervention meta-analysis. But start helping in groups and be part of a team, because this is a teamwork. You can't do it with like 2 or 3 persons. All right, that's it from my side. If you guys have any question uh, about today's session or about research in general, you can always, not always, I mean, just ask me here. You're welcome, Minha. I'm really glad it was clear. Also, don't forget to fill the feedback form. It helps us with our future workshops and our future projects. Please fill it. Or any suggestions you have, you guys can also give those. Thanks a lot, Faiza. All right. Sophia, you can take over. I'm done. I think she's not here. I can just end the meeting, right? We're done. If you have any question, you can ask in the group as well, of course, and ask about the mentorship as well. All right. Have a good day. I mean, the day
I'm
ahead.
here. Please don't
Okay,
forget to
okay,
fill the
okay.
feedback form, guys.
My
Thank
bad.
you so much for
You're
this.
welcome.
Hello, am I
Yeah, we
audible?
can end the meeting, right?
Yeah, we can end the meeting. Please do
Okay.
not forget to fill the feedback form, guys.
Yeah, make sure to fill the feedback form, please. Okay.
And thank you again for your participation. We hope to see you again in future Empower Desk initiatives.
All right.
Right.
Thank you
Right.
again.
Thank
Allah
you,
Hafiz.
Office.